Welcome to the April-May Forecast Direct, and I'm really excited about today's conversation. With me is Emil Verner, who is a professor at MIT and has written a paper that came to my attention, a really interesting paper that looks back at the 1918-1919 influenza pandemic and asks some of the economic questions that we're asking ourselves today about the current pandemic, but also what is quite interesting is Emil is a professor of finance. So going from finance, delving into COVID and the macroeconomy, kind of really interesting convergence of areas there. So welcome, Emil, and thank you for joining us.
Well, thanks so much, Jerry. It's a pleasure to be with you today. Look forward to the conversation.
So let's just start with this paper that caught my eye, and it's called Pandemics Depress the Economy, Public Health Interventions Do Not, Evidence from the 1918 Flu. And it's, of course, with your co-authors, Sergio Correa and Stephen Luck. And as I mentioned, you came to this from finance. So maybe you can give us a little background as to how you came to do this research and what was it that struck you as really kind of interesting here?
Sure, absolutely. So I think in a way there's two parts or two ways to answer the question of how we sort of came to look at this question of the impact of public health interventions during the 1918 flu. So most of my research focuses on the connection between financial markets and the macroeconomy, and especially trying to understand how in some cases financial markets can lead to a buildup of risks that results in financial crises that bring down the whole economy. And so in that line of research, one has to sort of think about externalities and issues of coordination problems in behavior. So for example, if I go out and take out a mortgage, and I may potentially become too indebted in a subsequent recession, like a lot of people did in 2005, 2006, in the run-up to the 2008 crisis. I don't necessarily take into account the fact that if I default, for example, if my home goes into foreclosure, that's not just bad for me, it's also bad for my neighbors, it's bad for my local economy. And so when thinking about financial crises, there's all these issues of spillovers, externalities, and that require coordination and behavior. And so early in the pandemic, this is back in January and February during the lockdowns in Wuhan and in Italy, I was thinking a lot about how the response to pandemic also requires thinking about externalities and about coordination and behavior. So, for example, I think as we all know by now, during a pandemic, people don't necessarily take into account that their actions, like going on a shopping trip or going to work, may have a negative spillover effect, or what economists call a negative externality on others, because you might be carrying a virus and you might infect other people. And because of these types of externalities, many people can become infected, become ill, and more people may become infected than what is even necessary to achieve herd immunity. So this is what epidemiologists call epidemic overshoot. And so an epidemic, that's kind of spins out of control, is of course going to be very bad for the economy, and is naturally going to lead to bad things. People aren't going to want to go to work. They're not going to want to go out and spend if they're afraid of getting sick. And so that's kind of where these, the fact that there are these externalities, these spillovers, these, the fact that we're all kind of interconnected and our actions affect each other, mean that there's potentially a role for coordination in a pandemic, like social distancing laws, social distancing policies that try to coordinate our behavior so that we don't sort of get too many infections at once and kind of are able to flatten the curve, as kind of we've all learned by now. And so those were kind of the important policy issues that we're still debating, but that were very much being debated back in February, March, April of 2020 around controlling the pandemic and sort of the costs and benefits of doing that. And so that's sort of the kind of theoretical background and kind of the relation to some of my other work, there's also kind of a practical, more practical reason that we kind of got interested in the 1918 pandemic, which is in a lot of my work and other people's work on financial crises, people focus a lot on historical episodes. There just aren't that many financial crises. Before the 2008 crisis in the US, there was the last major crisis was in the Great Depression. So you kind of have to go back, almost 80 years to really have another major systemic crisis. And fortunately, pandemics are similar. Pandemics, are even rarer than financial crises, luckily. And so, the closest parallel that we had to the coronavirus pandemic is, the 1918 pandemic. It's far from a perfect parallel, but it was sort of the closest parallel. And so, as the pandemic was erupting, and we could see that it was going to also affect the US, we started looking into what the experience of the US was during the 1918 pandemic. And that sort of historical perspective to finance and macro research led us sort of naturally to have a historical perspective on kind of the macro effects of previous pandemics and health policies.
Yeah, and that's a really interesting period to look at as well. At the beginning of this pandemic, we knew very little about what happened in the economy then, and there was one study comparing St. Louis and Philadelphia, but not a lot else. So the responses, the coordinating responses that you're interested in, those were on a citywide level, and they differed across the country. So maybe you can tell us a bit about what those were like and how they differ, if at all, from the statewide responses that we've had this past
Right,
year.
yeah, that's exactly right. So, when the second wave of the 1918 pandemic arrived in the US in late August of 1918, it first arrived in Boston and then kind of relatively quickly over the course of a few weeks spread throughout the Eastern Seaboard down to New Orleans, and then across to the West Coast and then inland. So the virus, the influenza virus, spread kind of over about a month, relatively quickly. And different cities were hearing, for example, about the high mortality that was happening in Boston and in Philadelphia, but there wasn't really a coordinated federal response. In fact, the US federal government was mostly focused on fighting World War I and raising financing and producing munitions to fight the war. So there wasn't much kind of focus from the federal side. And so cities had to really act independently. And cities responded, in different ways. Some responded sort of relatively quickly and aggressively. Others responded more slowly, which, the differences kind of are down to kind of a variety of reasons, much like today. Some of it is about information. So the cities that were hit relatively later in the pandemic, like cities on the West Coast, responded a bit more quickly relative to their outbreaks, just because they had heard about how bad things were, on the East Coast, in Boston, Philadelphia, and so they decided to take action more aggressively. Whereas other cities, for example, also for local political reasons, didn't respond. And so, in terms of the responses that you saw across cities, most of the major cities in the US implemented some form of public health intervention. So the most common ones were closures of schools, closures of churches, closing down of places of sort of public amusement like theaters, movie theaters, saloons, dance halls, bars, cafes, hotels, kind of all of those types of public places were closed in some cities, and some cities sort of closed all of these places. Lots of cities also introduced public gathering bans to sort of prevent what today we would call super spreader events. So, examples include, the Liberty Loan parades that were held to raise financing for World War II. Some cities decided to call those off, whereas other cities kind of, because they wanted to meet their Liberty Loan targets, actually didn't call them off, and those resulted in mass spread. So Philadelphia being the most famous case. There were also other policies that are kind of are similar to what we've seen today. So courts were closed, federal, state courts were closed, much like they were today. Business hours were, staggered, in part to limit the number of people who were in public in public transit. So there was really kind of a broad range of policies that were applied for anywhere between 1 week to 10 weeks, with an average of about 4 to 5 weeks across cities. So, comparing to the experience we've had today, these were kind of in place for a relatively shorter amount of time. So they were kind of in place for, on average about a month. In terms of kind of thinking about that question of how the policies compare to what we've seen today, I think you can kind of see that there's some pretty clear parallels. There were, closing of lots of these public places. They were sort of, compared to, for example, the closures of all non-essential businesses, they were less stringent. And they were also, as I mentioned, of shorter duration. And I think the way to think about the comparison is really that in 1918, in large part, the policies at best served to sort of mitigate the pandemic, to prevent, what epidemiologists today would call epidemic overshoot, that is preventing sort of too many people from getting infected relative to even what you would need for herd immunity. Whereas today, there's been, the policies have been used in part for mitigation, but also in some places, in some cases, for suppression, or at least for the goal of suppression. I think back in March and April, it was a little bit unclear exactly what the US was doing. Were we just kind of trying to flatten the curve, or were we really trying to suppress the virus? Like, for example, other countries have done, like, China or New Zealand or Australia. And I think essentially we've also ended up going for sort of a mitigation strategy, but where we really flattened the curve more and spread it out over a longer period of time than the 1918 pandemic, which where these policies were in place for a month or two, usually.
And that was the explicit idea in California. The policy was to reduce the rate of infection so as to not overload the healthcare system. And if that meant spreading out the amount of time, that was considered a reasonable trade-off in terms of public health policy. One thing that strikes me that is actually somewhat similar, that in 1918, these restrictions were on cities, not states, but people didn't move between cities very often. So you didn't have the kind of interaction that you now have between Boston and New York and Philadelphia, or San Francisco and LA and Orange County going on. So they're a little bit more isolated, and maybe that makes the shorter duration kind of comparable, even though the time frame is a little bit different.
Yeah, I think that's right. I think cities were more isolated. There was relatively less mobility. The car was still relatively recent, not so widespread, so people couldn't as easily travel. The flu, of course, did travel across cities through the railroad network, for example. So there were, of course, the flu, of course, did kind of spread. A big part of the spread was also World War I troop movements. Mm-hmm. So you kind of see that, the epidemic essentially peaks or is always, a few weeks ahead in the military population relative to the civilian population, and often military personnel who were, being moved around to different bases, being sent to Europe, would bring the infection to, a new place, and then it would sort of spread to the civilian population within a week or two. But it's true, cities were relatively less connected than they are today, just kind of by virtue of transportation technology.
Yeah, let's talk a little bit about your data, and that's an important issue today, as to, what does it mean to have these non-pharmaceutical interventions? One really useful piece of data or data series that I've been looking at is the Oxford University's measure of stringency of NPIs, of non-pharmaceutical interventions. But if you look at it, it kind of moves all over. And just as, for example, The state of Michigan, very stringent, and then basically none. Or you have Texas that it turns out on the Oxford Index, Texas looks like they have a little bit above average, a little bit above median stringency in their interventions, but Texans don't really follow the intervention rules. So it's confined to, a few places such as Austin and Houston. And so using that data, it's reasonable data, but it is data that you have to be careful with. What about, the data that you used? How did you measure that stringency of interventions and the variability over time of when the interventions came in and when they were eased?
Right. No, I think that's a really good question. And a lot of the issues that come up that you mentioned, also arise and you see in the data in 1918. So some cities, closed, then opened up again, and then closed down again. So St. Louis, for example, did this with their schools, and so they kind of switch on and off. We have evidence of kind of differences in rates of compliance as well. So in terms of where the data are from on the non-pharmaceutical interventions, here we're kind of building on a kind of large effort by a group of epidemiology researchers led by Howard Markle and his co-authors that essentially back in 2006 got together and sort of combed through public health notices, newspaper reports for the 43 largest cities in the United States, and essentially recorded, all of the start dates and policies that were in place, and grouped them into different categories. So they recorded, for example, when schools were closed in each city, whether cities had public gathering bans, whether they had other types of closures that were mandated. And those types of policies like school and church closures are relatively sort of, objective to measure. There's other kind of policies, for example, mask ordinances, where there's lots of evidence that there was, compliance among some, but also lots of opposition to it as well. So just to give you an interesting story, there was a lot of debate about, whether masks were useful in 1918 as well. And actually, San Francisco was one of the cities that, where the local public health director kind of was a big believer that masks would slow the spread of influenza. And so there was a mask ordinance that was put in place that was then lifted in November. But then as the flu came back in December in San Francisco, in December of 1918, they wanted to put it in place again. And there were some people who were just so fed up with wearing masks that there was actually an anti-masking league that was started, essentially, in opposition to the fact that, this went against, people's civil liberties. And so you do sort of see this evidence of lack of compliance with some of these policies. And so that sort of makes, as you said, for today, makes measuring the incidence of these policies imperfect, but they kind of give an approximate sense of how stringent or not kind of different cities kind of intervened. And what the epidemiology studies that I mentioned before generally find, which sort of supports the idea that these policies were useful, is that the cities that were more aggressive in their policies were able to reduce their peak mortality, that is the highest rate of mortality in a given week, by 40 to 50%. And so they were kind of able to flatten the curve. And to some extent, they pushed deaths further out into the future. So further into, from October of 1918 to November of 1918 and even December of 1918. But they didn't push all the deaths into the future. So if you sort of look at the data, it looks like total mortality was reduced by about maybe 15, 20% in the cities that intervened more aggressively. So it does look like these policies, had some effect, but they in the major U.S. cities, they were far from perfect. There are some smaller cities in the U.S. that aren't in our data, where there's evidence that essentially the cities were able to keep out outsiders through sort of protective sequestration, as some people call it, and were able to avoid the flu getting in, and so managed to escape entirely. Australia had a naval quarantine and actually managed to escape the worst of the 1918 pandemic because of that. But for the most part, for major U.S. cities, that wasn't the case.
So it seems that politics always enters into both public health and economics.
Absolutely.
I was reading that the US wanted to follow the Australian model, and there was political blowback saying, no, the doughboys need to go home. They've been in Europe. Let's let them go home. And that was part of a super spreader kind of policy.
Yeah. And within, and you kind of, in reading the history, you see the tension between public health experts that, for example, asked for troop movements to be suspended in October of 1918, at the same time as the U.S. government is fully focused on sort of finishing the war, and kind of there's some rumors that the armistice may be relatively close at hand. And so, the public health experts are often not able to get their advice kind of passed through because of other considerations. You see the same, for example, local public health experts in Philadelphia, were warning against having the Liberty Loan parade, but again, that we talked about before, but again, policy sort of politics intervenes, and there was lots of opposition to these policies. Especially from, for example, local businesses who, worried that it was going to hurt their revenues. So definitely politics intervened with public health.
Yeah, so the bottom line in your research is that these public health interventions, they not only lead to better health outcomes, but also better economic outcomes. And yet the discussion in the US is certainly about there's a trade-off between public health outcomes and economic outcomes. So how did you reconcile that this actually occurred in the 1918-1919 timeframe?
Right. So, that's exactly right. And as we were working on this in February and March of 2020, there was lots of discussion of how, well, the cure can't be worse than the disease. Having these social distancing laws can't completely, we can't sacrifice our economy completely. We have to kind of balance this trade-off. And of course, we sort of thought to ourselves, well, if you think about it, there doesn't have to be a trade-off, because if you can control the pandemic, that's of course also going to have some benefits for the economy. And so what we did was we collected data on city level measures of economic disruptions that are put out by a trade journal at the time called Bradstreet's, that recorded sort of how different cities were doing. And what we found is that in the short run, so during the fall of 1918, the cities that intervened more aggressively and were able to flatten the mortality curve actually don't do sort of meaningfully, clearly worse in their economic performance kind of in the fall of 1918 as they have these policies in place. And then if you look to the year after the worst of the pandemic, so if you look to 1919, you see that actually, if anything, the cities that intervened more aggressively actually have higher economic activity, relative to before the pandemic than the cities that intervened less aggressively. So, the way we interpret the results, sort of, we try to be somewhat cautious and interpret it as saying that, there's not really clear evidence that there's a strong trade-off between health and the economy. And, our rationalization for this, and there's lots of historical kind of narrative evidence that's consistent with this, is that, the recession itself and the pandemic itself and the disruption that it caused, is itself very disruptive. And so, using these policies that sort of coordinate behavior and are able to flatten the curve, they can actually sort of have indirect benefits for the economy, even though, of course, directly they're reducing economic activity. Indirectly, by slowing the spread of the virus, it mitigates the amount of, both direct illness and mortality, but also the fear and panic that arose because of kind of the just how severe this virus was. So just to give you kind of a concrete example of sort of the direct effects of the virus. So in Philadelphia, which we talked about before, which was a city that on the spectrum of interventions was one of the least aggressive, intervened relatively late, and saw very high mortality. In the first half of October, over 800 employees at the Bell Telephone Company in Philadelphia stayed home from work, either because they were sick or because they were too afraid to go to work because they were afraid of getting sick. And as a result of so much absenteeism, so many employees staying home, the company actually took out a full-page ad in the Philadelphia Inquirer, basically asking people to only use the phone. They could only process phone calls for essential calls that were either related to the war or that were essential because of the pandemic. And so it's you have lots of examples of business being completely disrupted by all of the illness, all of the fear, all of the panic. And the cities that were able to kind of flatten the curve, they were also able to some extent to mitigate these severe disruptions that come from just such high rates of illness and mortality. And I think what you've seen in 2020, and there's a fair amount of research that seems to find this, is that the places, the countries, and the cities, states in the US that intervened more aggressively and had more stringent social distancing policies or lockdowns didn't tend to do so much worse, and some of them actually even did better economically. And I think it's a similar argument that the virus itself, the pandemic itself, leads to a lot of fear and disruption. And so in some sense, using policies that slow the spread can mitigate those negative economic consequences of the virus itself.
I think that's right. I've been looking at data for the US and coming up with the same conclusion, and also Scandinavia, although it's a small number of countries. Early on, the discussion was that Sweden was choosing a more open economy and less public health intervention, but it appears that the same results that you found are true there, that other countries in Scandinavia, Iceland excluded because it's so heavily dependent on international tourism. Sweden had no better economic outcomes and actually on average worse, and worse health outcomes. And I think what you've just described is both a demand and supply response, right? The supply because workers were afraid to come to work or they were ill, and a demand because people were afraid to go and buy those services.
Exactly. Yeah, no, I think that's been one of the interesting things in the pandemic is it's a different type of shock and recession from what we're used to, and exactly, it operates on both demand and supply sides. And in Sweden, for example, what you've seen is that while some people have used the opportunity to go to bars, go to restaurants because they weren't closed down, or at least in the spring of 2020 weren't closed down, lots of other people became even more afraid and actually decided to stay away. And so by basically controlling the virus, like for example Norway did or Denmark did, I think more successfully than Sweden, actually you're kind of able to keep those people who are really afraid from kind of reducing their demand so much. And so there's some really nice research that compares Denmark and Sweden and actually uses individual level spending data that shows exactly that in Denmark, what you see is that the more stringent lockdown policies depress the consumption of sort of young people, for example, who are probably less afraid of the virus. By the time kind of people realized that mortality for younger people wasn't that high. But actually, you see that for older people, you have the opposite. You have that older people in Sweden really reduced their spending, and especially spending that required, going out, into large crowded stores, or going out to a restaurant, because of that sort of fear of the virus, and that's why sort of these policies, don't translate necessarily one for one into a trade-off, because people kind of are going to respond to the environment that they're in.
Right. So let's turn back to your major field of interest, finance. There's the Biden administration put through a $1.9 trillion support and stimulus package. The Fed is flooding the market with liquidity through QE. That is intended to stabilize the macroeconomy, but you study financial crises. Is this also leading to a potential financial crisis? What is your view of this macroeconomic intervention as opposed to non-pharmaceutical intervention?
Yeah, that's an interesting question, and here there's I think even more limited historical parallels, because as we've touched on before, this really is different from all other recessions, and this recession is a recession that's driven very clearly by a pandemic, and it's interesting. I always say this: it's rare that we have a recession where we understand the root source of it so well as this recession. Normally in 2008 with the financial crisis, we were debating, was it the housing market, was it the banks, was it both, was it oil prices, lots of different factors. Here it's relatively straightforward, but at the same time we don't have as much experience kind of in thinking about this macro environment. The way I think about all the stimulus that we've seen is, I think of it less as stimulus and more as relief for people who have lost income because of the pandemic, and we know that the impacts of the pandemic have been very different for different people in different occupations. There's been lots of inequality in that dimension, and so I think this stimulus, in some ways, is a relatively imprecise tool for targeting the people who really need the help. But it has provided crucial relief to lots of families. Lots of other people have taken that stimulus and just saved it. So we've also, for example, seen very, very high saving rates. I saw a recent comparison actually to World War II, which is actually an interesting comparison, because World War II also saw very high private saving rates, and people's consumption was suppressed during the war, and the estimates of fiscal stimulus tend to be smaller. The effectiveness of fiscal stimulus, or the multiplier on public spending that people estimate, tends to be smaller if you look at World War II. And I think we're a little bit in a situation like that, where the effects of the stimulus, at least during the pandemic, are smaller than they would be during normal times, or during a normal recession where we sent out checks, because lots of people are just going to save the money. They're not ready to go out and spend yet. And I think once the virus really comes completely under, or much more under control, which is hopefully kind of happening now as vaccinations are really picking up, and around half of Americans, as today we're speaking, have received at least one dose. I think we're going to start to see some of the stimulus maybe generate more of an economic kind of kick, and I think that will hopefully lead to a strong, and I think will lead to a strong recovery. And so then we kind of get into the questions of whether maybe the stimulus has actually been too large, and there's some interesting questions around that we can talk to. I think we may end up realizing that the stimulus was quite large, especially relative to the output gap, and that may lead to some kind of inflationary pressures on the other side. But I also think that we're kind of in a position where it's probably better to be bold and to try too much than try too little.
And we, in fact, don't have any empirical evidence to support the view that it's too large. That's just speculative, right?
Well, I think the people who say that the stimulus is too large make, I think, the reasonable observation that if you look sort of relative to the output gap, um, then the amount of stimulus, if you put together sort of the stimulus from December with this 1.9 billion package, and then potentially also an infrastructure package, would amount, would be several times larger than the actual output gap in the economy. And so, in some sense, whereas, for example, in 2008, the stimulus, was about, a third to a half the size of the output gap, depending on how you measure it. Today, the stimulus is, larger and several times larger than the output gap, depending on your exact estimate. And so that suggests that it is really quite a large stimulus. If I can kind of think back, to the policy interventions that we've had, I think, the relief that we've provided has been very important. I would have liked to see relatively more spending on controlling the pandemic, especially early on during the summer. I think that the more money could have gone into scaling up testing and sort of using testing and tracing more effectively to kind of slow the spread. I think that would have helped the economy open up more quickly. And I think kind of with the most recent debate about stimulus, I think I'm more positive about the stimulus that focuses on kind of building up infrastructure and also thinking about meeting longer term challenges than, kind of stimulus, sending out checks and so on, which I think, while important for some families, is a pretty, imprecise tool for dealing with the pandemic, given, how dispersed the consequences of the pandemic have been, and how some people, really haven't seen much income loss, whereas it's been devastating for others.
So this has been really interesting. We're just about out of time, but the way in which finance and the disparate response to the pandemic and the economic consequences, it's not obvious that it's the same as people were saying in the beginning. And so your research is both quite interesting and very, very much revealing. So on behalf of UCLA and the Anderson School and the Anderson Forecast, I want to thank you for joining us today.
Thank you very much. It's been a pleasure to be with you.